GVH. And this is data from my colleague Sarah Cooley, and this is looking at some of the NK cell receptors. So there's a group of receptors called the killer immunoglobulin receptors, or KIR receptors. And these receptors are what controls NK cells. And it turns out that there are about 15 of these receptors. And if you take all humans and separate them, some people have about 8 of those receptors, and some people have 15 of those receptors. And if you look at these people, the ones that have more receptors, the rate of leukemia relapse is actually lower if the donor has lots of these receptors than if the donor has less of these receptors. And so this kind of opens up the opportunity to pick donors based on these characteristics. As you can see, only 10% of this really large cohort of patients have this characteristic. But again, there's now going to be a study where we can predict who those people are and potentially pick those donors in real time as we're doing bone marrow and cord blood searches. The last kind of point I want to talk about is this concept of fetal microchimerism. So fetal microchimerism is the idea that the fetus, some of the fetal cells actually leave and go into the maternal circulation, this red baby and these red cells. And some of the mother cells actually go into the fetus themselves. And this is well established now. This happens in all pregnancies. And the idea is that when the maternal cells get into the patient, when the maternal cells get into the baby, that the baby should be tolerant to those mother cells, including the mother's HLA, okay? In contrast, the mother recognizes the fetal cells and gets rid of them. And really what the mother is recognizing is the father's HLA, okay? So it's just shown a different way. This is the mother in a very simplified manner, but just presume this is HLA, and this is the father. And then they have a series of 4 children. So this child inherits an A from the mother and a D from the father. This one inherits a B from the mother and a D from the father, and so on. So then the non-inherited maternal and paternal alleles can be immunogenic and can be used to pick donors. And so for the NEMA, or the non-inherited maternal antigen, that would be B. So in other words, in this particular case, any of the mother's cells that the baby sees a B, the baby will be tolerant of. And so then if you take that cord blood unit and find a donor who has a B, that person would be more tolerant. Conversely, the C, again from the father, some of the mother cells will get into that cord and will recognize C. So if you have somebody with C, you'd predict that that person might relapse less. And I'll show you that data. So this is really pioneering work by Jan van Rood. And if you look, this is the rates of treatment-related mortality in patients who are mismatched at one antigen. And so if you're mismatched and you have that tolerance match, the rates of treatment-related mortality are close to 0 matches. But if you don't have that match, the rates are much higher. So in other words, what it says is that cord is tolerant to that patient if that match is present. Conversely, if the mother cells get in and the baby if the baby cells get out and the mother recognizes those cells, the rate of relapse is relatively low if you have a inherited paternal allele, but the rates of relapse are much higher in the opposite situation. Lastly, and this has already been covered, but one of the things that has really guided our therapy in the last let's say 3 or 4 years, is the presence of pre-transplant minimal residual disease. And we've already talked about this today, so I'm not going to spend much time. But I think that really this is the first study by the German BFM group, by Bader and colleagues, to show that if you have minimal residual disease prior to transplant, your chances of being alive are much lower than if you don't. And that the reason for that is because of relapse. And so really being able to pick the time of transplant is critically important, and it depends on the presence of minimal residual disease. And so now if we have patients who come to transplant and have high levels of minimal residual disease, we'll try and give them more chemotherapy. And in most cases, we've been able to clear that. And I think what happens is essentially these patients, right before transplant, they have certain levels of disease. And then during the conditioning therapy, in the patients with really low-level minimal residual disease, it gets even lower. And then there's time for graft versus leukemia reactions. And in the patients, in these patients, they're more likely to be cured than these patients where some will go on to relapse, but some will actually achieve long-term remission. So then what do you do with the patients who are either really high risk of relapse or you just can't clear their minimal residual disease? And so this is work that we're currently doing, and this is based on old data from Seattle, where in Seattle they tried to increase the dose of total body irradiation to 15 gray. And when they did that, what they found was they had less relapse, but there was more toxicity, there was more treatment-related mortality, and ultimately there was no change in overall survival. And that's where we really came up with the 12 gray of total body irradiation. And so now we've purchased this machine called a tomographic irradiator, which is a CT scanner and a radiation head. And we can sculpt the radiation to the whole body. I'm not sure if I can get that movie to work, but the patient kind of sits on the bed and moves through this machine as every bone in their body is being irradiated. And really what this looks like, this is a pseudo-color image where with total body irradiation, every single tissue in their body gets the same dose of radiation. However, with total marrow irradiation, which is what we've now created these algorithms to do, we can kind of catch the bones on tangents and just irradiate the bones and spare the heart or the lung or the liver. Now the patients still get chemotherapy, and so this is an ongoing study, but it's a dose escalation study, and we'll see how this works. But the goal is to try and give either 18, 21, or 24 gray of radiation to these very high-risk patients. So in conclusion, double cord transplant has undoubtedly increased the opportunity for patients to go to transplant. The mechanisms, whether there's more GVL and GVH, is still not clear, and refinements are still needed. Lastly, I'd like to thank some of the people I worked with who have really made this happen. Claudio Brunstein and Juliet Barker are some of the adult bone marrow transplant doctors who I work with very closely and have been instrumental in these studies. Margie McMillan did all the GVHD work. Susanta Hui is the physicist who I work with on that last section. And Bruce Blazer, Jeff Miller, and Dan Weisdorf are some of the leadership of our center and have been instrumental in these studies. Todd DeFore is the statistician who does all of these curves. And lastly, John Wagner's my boss and has been incredibly supportive to allow us to do this work and has been the driving force of the majority of these studies. So at that, I'll stop and take any questions. Thanks for your attention.
Le vamos a pedir al doctor Valero y a la doctora Brenda que se pueden subir con nosotros y tomar asiento para poder escuchar las preguntas de la audiencia. Si tuviera alguien alguna pregunta, la podemos empezar a recibir. Yo quisiera preguntarle al doctor Valero si ustedes si han usado dasatinib por alguna situación en especial. O sea, por ejemplo, el dasatinib se ha reportado que pasa barrera hematoencefálica. ¿Han tenido ustedes por ese motivo el uso de dasatinib, sobre todo en un paciente con leucemia aguda linfoblástica o por alguna otra situación?
Sí, realmente en esta situación es la disponibilidad del medicamento. Y sí, o sea, tenemos dos casos con mantenimiento con dasatinib. Las principales limitaciones que hemos tenido son los efectos en la neutropenia, pero comparando las dosis que se manejan a nivel internacional de 100 miligramos en mantenimiento Realmente nosotros hemos mantenido la dosis mínima, que es la que ha tolerado el paciente, 25 miligramos cada 48-72 horas, pero sí es por la disponibilidad del medicamento en estos dos casos que se ha tenido.
¿Alguna pregunta? ¿Alguna pregunta más? Al doctor Michael Berneris,